Hi everyone! Last month I had the opportunity to travel up to Vituity Central headquarters in the Bay Area where the leadership team put on the 2024 Operational Throughput Collaborative. About a year ago, I put a video together where I talked about the importance of patient experience. We had 3 initiatives that came out of that collaborative, and similarly with the operational areas of opportunity that have been identified through, well, your hard work and that of our team, we have 3 initiatives for this collaborative as well. But again, it would be pretty presumptuous of me to impose change without providing you with the why. I think this picture explains the first piece. When the department looks like this, we feel like this. Short of 120% staffing across the network, wellness on shift is the most important way to address physician and provider burnout in emergency medicine. If we can't take care of ourselves, then we certainly can't take care of our patient population. I think we all agree that a shift where we're moving patients through, admitting to the floor without difficulty, consulting without pushback, and operating at the top of our license feels great. It feels like we're really doing the right thing for our patients, doing our job, and we leave shift feeling like we've made a difference. We want to see lots of these. The flip side of that is when our board looks like this. Patients aren't moving through and they only keep piling in. These are the days where you feel like you're walking through molasses and you end up leaving at the end of your shift feeling like you've worked 3 shifts rather than just 1. It's not all anecdotal. While the most important part of throughput in my mind is the wellness of healthcare professionals, there's a lot of really good data that shows specifically the effects of throughput on patient safety. I'm going to make this really easy for everyone. Continuous improvement in throughput is important because it impacts mortality. Mortality. Throughput is important because a high length of stay and boarding time is directly correlated to mortality. We want to improve throughput because we want to decrease mortality. The sick patients are why we went into emergency medicine. If we're not doing everything we can to prevent mortality, we are literally not doing our job. For those of you who don't like walls of text, this nifty graph shows you what length of stay does to mortality. That big red arrow shows you a linear increase in, that's right, mortality. Shaving an hour off of length of stay decreases mortality by 0.1%. Think about it. You decrease 1 hour of length of stay for 10 patients, and you've decreased your mortality by 1%. That is huge. So where do we currently stand, and what are our goals? Here are our turnaround times to discharge by ESI. ESI 3 through 5 are the most impactful since the majority of these patients get discharged, while the majority of ESI 1s and 2s do not. These are by minutes, so ESI 5 is at 89, 4 is at 151, and 3 is at a whopping 217, which is pretty common. Those ESI 3s by far are the patients that cause the greatest burden on the emergency department in terms of management, since they can go in either direction, admission or discharge, and oftentimes are a little more complex than we initially think. Here are our goals by ESI. We have quite a bit of room for improvement, which is actually great. It gives us the opportunity to shine. What does Adventists ask? They want a total TAT-D of less than 180. Our total TAT-D right now is around 220, which really makes 180 attainable. Many of us have worked at sites that have TAT-Ds in the 300s, which is a tough starting line. So let's talk about how we're going to go about reaching this goal. Our initiatives. Let's dive in. Okay, so really it's only 2 initiatives because the first 2 are what are really going to operationalize our change in metrics. The third initiative I'll say a little bit more about in a minute, but the major 2 changes we're looking at are to institute a hardwired provider-only discharge. Other sites have also called this rapid discharge or rapid DC, and a modification to the physician's schedule to support a physician at triage. This is probably going to be our heaviest lift, but has major implications for process improvement. And the third is to initiate multidisciplinary rounds, or MDRs. So provider-only discharge. This is for ESI 4s and 5s for which no nursing intervention is needed. The RN at triage performs their tasks and then the patient is assessed by a medical provider. That provider determines the patient can be rapidly discharged. For example, a toothache with dental pain who really just needs a couple prescriptions to bridge to dental care. And the patient is discharged by the provider, paperwork printed by the provider, and the time of discharge is noted on the tracking board so that the nursing team can back time the discharge of the patient when they get to it. There are a set of clearly defined rules that Vituity uses, and this educational information will be sent out prior to our go-live date. So it's no secret that when the bus drops off, it's usually in the front. It's not always the case, but we have been seeing increases to our left without being seen, and those patients are classically on the front end. So this is our schedule on Mondays and Tuesdays. Someday, when our staffing is where we want it to be, we should be fully at 4 physicians a day, 7 days a week. For now, we're only piloting this on Mondays and Tuesdays because it only works with 4 physician days. This is the new model. The 6 a.m. physician won't be able to have triage duties as they typically will be managing the whole department for the first hour of their shift. But each physician shift after the first, as represented by the black overlap, is time at triage. During this time, they are responsible for championing the front end, being present geographically in that location, and seeing patients that walk in. But Dane, what happens if the 10 a.m., 4 p.m., or 8 p.m. doc comes in and the EMS bay looks like this? Well, then yes, you're absolutely right. The physician needs to help identify which patients are sick that the previous doc hasn't already seen and help out as needed. As soon as those patients are triaged and managed with orders, those physicians are still expected to spend the rest of those first 2 hours at triage to help offload the front. For both of these first initiatives, our successes will be measured as a decrease in our TAT-D for ESI 5s, 4s, and 3s. Our third initiative is multidisciplinary rounds. MDRs for short are a standardized way to assess the state of the department. It should involve as many members of the team as possible, although obviously those dealing with acute issues are exempt. While there are some success measures attached to it, this is seen as more of a secondary initiative to the first 2, as it's designed to help support the overall throughput of the department. Here is Riverside's rounding checklist, which we will probably use some of, but certainly not all. We want this process to be fast because everyone on shift is busy, 5 minutes or so if possible. As always, a plan needs to be explored, tested, and finally hardwired, and we're going to need all hands on deck to be successful. But the potential payoff is huge. Our go live, everyone, mark it on your calendars, is June 1st of this year. It's plenty of time to identify any barriers, discuss a plan, and implement the changes. And one more thing. I really am not a fan of financially motivating us as a team. That being said, working for pay is a part of being a functioning adult, and so I do have to mention that if we can make our benchmark goals, we're fortunate to work within a healthcare system that pays us for hitting our metrics. This means more money in the surplus for everyone, which I don't think anyone is upset about. Let's keep in mind that the reason we do this is for our patients, just as that's the reason that we got into this field to begin with. Keep on the lookout for more materials and education on how we will plan to institute these changes. From the bottom of my heart, thank you everyone for your attention, support, and to the team that accompanied me to the Bay Area to participate in the collaborative. I'll see you all in the department.